Hello, everyone. Thank you for joining me this morning. I'm Dr. Malia Jones of Dear Pandemic, and I'm really excited to be joined this morning by two of the members of our little nerdy neighborhood, our nerdy collaboration. I'm joined by Liz Marnick of ScienceWhizLiz, mostly on Instagram, and also by Sabina Vora-Miller of Unambiguous Science. And we're going to drop the links to both of their science communication pages in the chat box right now. Liz is an immunologist and geneticist, and she's spent a lot of her last year in her spare time myth-busting COVID myths on Instagram. And Sabina has an MSc in clinical pharmacology and is the face behind Unambiguous Science, which is another science communication site that's been doing the hard work of getting real COVID info out there. So thanks so much for joining me this morning, both of you.
Yeah, thank you so much.
So I just wanted to chit chat a little bit. As we were getting ready for the show in the background, had a really funny conversation about Canadian geese. How are the Canadian geese treating you, Sabina?
Vicious as ever.
Liz, did you say you don't have Canadian geese in Maine?
No, we do, but I never really realized that they could attack people and make them have injuries that required hospitalization. So that blew my mind. So now I'm a little bit worried about the next time I see a Canadian geese.
They're the worst. They just, they're messy and they chase people and they bite.
And they go for the eyes.
Oh, I definitely didn't need to know that.
So here in Wisconsin, we have a lot of Canadian geese, and they like to hang out on the sports fields, especially. And so anytime there's a jogging path that goes past the sports fields, there's like a lot of goose versus human interaction. And I was telling Sabina, who is located in Canada, that my little joke about the Canadian geese is that whenever I see them being jerks, I yell at them, "Thanks a lot, Canada."
It's our only contribution to the world, you know.
Fortunately, you've given us more than just the Canadian geese. So
there's also Justin Bieber, so there's that.
And Tim Hortons.
Touche.
So I have a huge thank you to Bridges for the Deaf and Hard of Hearing this morning for providing live closed captioning and ASL interpretation services. Thanks very much for providing that, Bridges. And if you're using those services, please let us know in the chat box, because that is what helps us keep it going into the future here. And just as a reminder, we don't take questions live during the broadcast. We pick them in advance because we like to be able to look up the answers to them and make sure we're telling you the right thing. So if you have a question, you can put it in our question box, which is on our website, dearpandemic.org. And how should people submit questions to the two of you?
They can find me on Instagram at ScienceWhizLiz, and I have question boxes that are popped up into my stories all the time. I also have a website. It's elizabethmarnickphd.com, so people can submit questions there.
And I'm Unambiguous Science on either Facebook, Instagram, or website if you Google it. And on Twitter, I am SabbyVM, so super easy to find me there too.
Awesome. So I have a warm-up question for Sabina. I don't think I previewed this question for you, so I don't know is an acceptable answer here, but I thought this was a really fun question to start off with. Virginia from Ontario asks us, she says, my son's girlfriend recently had squirrels removed from her attic, and they are now having mysterious bites. Our son caught a flea on his clothes. They live in Toronto, which is suffering from a huge surge of coronavirus, and we're going to get to that issue later. But meanwhile, can fleas be carriers of COVID?
Good question. So from my understanding, based on the data we have so far, COVID-19 is not bloodborne. And so, you know, we've tried to look to see whether there's any viral, particles in blood, and we haven't seen that. So, you know, the likelihood of it actually being transmitted through fleas is exceedingly low to pretty much impossible.
Liz, what do you think?
Yeah, I agree. Yeah. I haven't heard of any reported cases of that type of transmission from mosquitoes or fleas or anything like that. So I think it's a very, very low risk.
Certainly fleas can't be infected with COVID-19. It does not infect insects. And so it would have to be something where like the blood from one person was carried to another person, and it doesn't even look like it's bloodborne. So I'm gonna agree.
Yeah.
3 out of 3, that's a no. Okay, so now to the questions that we actually did preview. So we'll have more firm answers to these ones. So we've got to talk first about the J&J and AstraZeneca blood clot issue. Here in the US, we don't have the AstraZeneca vaccine yet. We do have the J&J vaccine available. These two vaccines use similar technology to deliver the important bits to your immune system. And both of them have been linked with this rare blood clotting disorder. So what do you think? Was the pause for the J&J vaccine the right move?
I think so. I think right now, right, we need to make sure that people have confidence that these vaccines are safe. And the one thing we keep stressing to people is that we are monitoring safety events. We're making sure that they are actually safe for people to use. So I think once we saw that there was this increased potential signal, even though it's a very rare risk, it's important to make sure we understand who is at risk and the best way of treating it, right? Because these have to be treated a little differently than normal clotting issues. And by pausing, it's giving the CDC and the FDA time to get that information out to doctors and hospitals so they can best treat these conditions, even though they are rare.
Yeah.
Mm-hmm.
And this has been going on for a while with AstraZeneca, which is available in Canada, right, Sabina?
Yeah, exactly. And so in Canada, as of 2 weeks ago, we've basically paused AstraZeneca in anyone who's under 55, because what we've seen is, around 6.5 cases per million doses. So again, very rare. But what we've seen is that this tends to occur, for the most part in women under age 55, and usually within the first 4 to 20 days after you get the vaccine. And I think that it's important for everyone to remember that everything in life comes with a risk benefit analysis, right? We take calculated, informed risks every single day, every single medication, every single activity. And I think that, that's the one thing that we have to consider in this, especially in countries that have a lot of cases right now, and where the risk benefit analysis in terms of what the risks of COVID infections are has to be factored in.
Yeah, and Canada is currently experiencing a tremendous surge in COVID cases. So those risks from COVID are not ignorable.
Yeah, and what we've done during this break is we're actually just trying to figure out, how do we diagnose, quickly, and whether there's actually any risk factors that make you more susceptible. So far, we've actually found that those who have been on birth control, those who are pregnant, those who have a past history of blood clots are actually not at an increased risk for these. So that's an important thing to know. And I think that the pause has really helped us try and identify, what is some of the triggers for these. It seems like it's an immune response as opposed to, your typical type of blood clots. So I think it is reassuring for a lot of people to know that, some of these factors of pregnancy or birth control don't put you at a higher risk.
Right. Liz, you're an immunologist. Do you have any sense from the J&J data in the US? What are there emerging risk factors for the blood clots that we're seeing here? It's my understanding that we only have 7 cases to work with, which is not a lot to get a signal from. So do you have a sense of if there are risk factors emerging?
Yeah, I think right now it's mostly the same as what we're seeing with AstraZeneca, that only one of the cases was reported to be on hormonal birth control. None of the cases had any pre-existing risk factors like a known genetic predisposition to clotting or pregnancy. So I think right now it's such a few number of cases that maybe there's some very rare genetic component that we don't know about, but right now there's no clear link as to why one person got this, why a bunch of other people who got the Johnson & Johnson vaccine did not.
Yeah, and what we do see is that it's been almost all women. There's been 1 man and
Right.
6 women so far, and all in that younger age bracket. So I agree. I think the pause was necessary. I wish there wasn't a very rare side effect, but the truth is vaccines do have extremely rare side effects sometimes, and that's why we have these safety monitoring systems. I think ignoring it or waiting for more data to emerge while we're distributing the vaccine is much more problematic, actually.
I'm actually going to throw a link in. I wrote a little publication on this in the newspaper today. If anyone wants to read, actually, the one thing that I really want to have people look at is like this graph that was actually done, this chart that was done by the UK, where they did this great risk-benefit analysis showing what the risks of COVID infections are, whether you have a low risk of COVID, a medium risk, or a high risk of COVID, and then based on age, where does that put you on the risk-benefit analysis with respect to these blood clots? And it's really interesting because looking at their data, they found only in a low COVID situation and under the age 30, only at that point you actually had to wonder about the risk benefit in that situation. But in every other situation, the benefits of the vaccine far outweigh any risks.
Yeah.
So I'll throw that in the chat if anyone wants to look at.
And I mean, it's my expectation that the CDC is going to unpause the rollout of the J&J vaccine here in the United States, possibly with the consideration of age. But I think, these are so unusual, and the risks of COVID itself are so much more dramatic that it will be, in all likelihood, it will get unpaused. So I also am dropping a link. I think we put a link in the chat box about what the symptoms are to watch out for.
Yep.
So you can check that out if you do. And, I actually think one of the biggest public health problems with this is probably the fear and anxiety people are experiencing if they've recently gotten the J&J vaccine. So I would just encourage people to treat that fear and anxiety as also a health issue, and do what you can to address your fear and anxiety. And there are a couple tips in that link from Dear Pandemic. We posted something about this last week. So one last question on this. What about the mRNA vaccines? Do they also sometimes cause rare blood clots, low platelets?
Yeah, so we have not seen any evidence of this happening with the mRNA vaccines. And the other thing I wanted to mention is if you combine both Moderna and Pfizer, because they're both mRNA vaccines, combined, they've been administered like 25 times more in the United States than the Johnson & Johnson vaccine. And the fact that we were able to detect these rare cases, there was only 6 at the time of the pause, in so few cases really shows us that this surveillance system works. And if we were seeing something similar with Moderna and Pfizer, we would know. And we definitely do not see that risk there.
Yes, I agree. I think it's, I feel for the people who've been affected by these blood clots for sure. And also for the fear that everyone's experiencing, because this is getting so much attention. But the fact that our monitoring system picked up 6 cases and then FDA hit the pause button, I find very reassuring that we would know if there were other issues.
Yeah, and I think that the important part here to remember is that all blood clots are not created equally, right? And so, I think when people are talking about some of the blood clots with the mRNA vaccines, I think they're talking about those regular, typical ones. And the rate of that was not higher than what we would see in the baseline risk. In the question that's coming up with the Johnson & Johnson and the AstraZeneca has to do with a very specific type of a serious blood clot, and it's not the same category as like a regular other ones.
Right. So just as this is in the header for this live too, but just a reminder that you should always seek the advice of your healthcare provider, and what you hear on Facebook does not substitute for their advice. Okay, so let's move on to, I've got another question for Sabina. This question comes from someone who's anonymous, who wants to know, as the most vulnerable people are now largely vaccinated, and here in the US that means by age, aren't we effectively dealing with a much less deadly virus? Can't we ease up restrictions at this point? What do you think?
Okay, so I think also, first of all, there are differences in what's going on in the US and what's going on in
Yeah,
Canada, because Canada right now is blowing up. We're basically
yeah,
on the brink of collapse here. But I think that a couple of things to remember over here is that, you know, in the early days, we thought that, or we saw for the most part, that COVID was mostly impacting those who were older with comorbidities. But right now, the situation with variants, especially, is a completely different ballgame. So here in Toronto, Canada, our ICUs are actually being filled with younger and younger people. So more than 50% of our cases are actually in younger people here. It's not uncommon to see 20s, people in 20s and 30s being intubated for very long periods of time. So, we are dealing with variants, and I like to call it a pandemic of variants, because we're seeing, even with, here the dominant strain now is B117, and we've actually seen that it resulted in a 100% increase in ICU and 60% increase in deaths due to it. So, I think that we're looking at a slightly different equation.
really scary.
Yeah, and the way vaccinations work during a pandemic, it's not our only way out, right? Vaccines only work if you still have your non-pharmacologic interventions in place, right? And so we need to be, until everyone is vaccinated with both their doses, if it's a 2-dose vaccine and 1 dose with the J&J, until we actually get to a point where we have that herd immunity. We all have to be cautious and take precautions until we are in a position where we can open things up slowly and gradually.
Yeah, thanks for that. I wanted to ask you that question because the situation is so different in Canada. And I think people in the US sometimes forget that the rest of the world's vaccine supply is very largely much, much lower
Yeah,
than
and
ours
like,
has been.
and realizing that there's so much cross travel between the
Yeah,
US and Canada, right? And like thinking about how many people actually cross the border on a daily basis. It's hundreds of thousands of people even today. And so, I think that in an era of globalization with neighbors that are friendly and have all this movement, you can't really, you're not a silo, right? And so I think
right.
that there is a risk, obviously, now for the US. Now there's these reverse travel bans that we have, so the US is being very cautious about anyone coming in from Canada. Um, so I think we're close to the end, but we're not that close either.
Agreed. So Liz, this is another question. You have focused a lot on the other problems that come with having COVID besides death. And this is, another reason why we can't just ease up restrictions now that most of the older people are vaccinated. So here's a question for you. And I think it came from a Liz, and I'm also directing it to a Liz. So it says, I've seen several articles saying that between 50 and 70% of people who've had COVID have lung damage. Is this true? And do we know if this damage could be permanent? And maybe you can also tell us a little bit about other kinds of long-term effects of having a COVID infection.
Yeah, so I think the first thing is we know that there are people who will get even a mild case of COVID who then go on to have significant long-term health impacts. And Sabina and I have been collaborating on a project to collect these stories and share them on our social media pages. So if you go to either of our Instagrams, you can see those stories and also submit your own if you're unfortunately suffering from long COVID. And we've wanted to bring awareness to this because it is a significant risk. The problem is we don't really have great numbers on exactly what percentage of people are affected by these. So it is true that reports have come out and has shown lung damage in patients who've even had mild cases of COVID. And it's also true that we also see things like heart damage in people who either have very mild illness or even in some cases of people who have asymptomatic illness. And I know recently there was a study that came out that suggested that up to 1/3 of recovered COVID-19 patients, even with mild disease, will go on to have mental health complications. And there's also been some evidence that there's even brain changes that can occur in some people who have COVID. So I think what we're really seeing is that there is this huge range of possible long-term health impacts. And in the stories that we've collected, we're also seeing people who they can't get out of bed, they can't take care of their kids. And a lot of these people were they had such a mild illness in the first place that they didn't have to get hospitalized. They didn't need to go to the emergency room, but now they're suffering and not able to work. Some people have lost their jobs. They've had to quit their jobs. So it really is profound. So I do think that people need to not only be concerned with death, but also need to be concerned about these other long-term health impacts. And we really still don't know the exact percentage of patients who will go on to have those. I've heard anywhere from 2 to 50% of COVID patients will then go on to have long-term health issues. I'm hoping as more studies are done, we'll get a better indication of actually what percentage it is, but we don't really know.
And I think it's a really interesting or important note that, why don't we know? Well, when this is still a relatively new disease to science, and it's very easy to figure out if someone has died or not, right? That's very obvious to everyone. It's not so obvious, and it takes longer to figure out exactly what the other long-term effects are, because we have to conduct, much more in-depth studies than what would be determining death, right?
But there is, I know both Mount Sinai and Beth Israel and Boston and a bunch of other hospitals are opening up these long COVID clinics because they are seeing such a flood of patients who are suffering. So hopefully we will find ways of treating and helping those patients, but also hopefully we'll understand better about why this happens in the first place.
Yeah. Okay, so Sabina, another Canada-specific question here, and this also affects lots of other places around the world. We got a question from Bonnie from Ontario who asks, here in Canada, we have to wait 16 weeks to get our second shot of the 2-dose vaccine. Is this going to be of any use? And what happens if we mix and match the Pfizer and Moderna vaccines? Will those combos even work? Any thoughts?
Yeah, this question comes up very often. So for those, who are not aware, in Canada, because of our situation with our variants being on the brink of collapse, and also with our high number of cases and very low vaccine stock, we've taken the guidance of our, you guys have CDC, ACIP in the US. We have a body called NACI here. It's the National Advisory Committee on Immunizations. And they've basically made this recommendation that second doses of the vaccines should be delayed to 4 months. And ideally, in an ideal situation, we would follow labels, we would follow clinical trials, but there's absolutely nothing ideal about being in a global pandemic, right? And so we're trying to be the most resilient we can be and trying to see, whether there is a possibility in this race against variants that we can protect as many Canadians as we possibly can. So yes, 2 doses gives us really good efficacy, but we're seeing data coming out, especially from UK that has taken the 3-month stance, that we are still having a really good immune response at the 3-month mark with just 1 dose. So we have this data, and the way antibodies work, they don't really go from 100 to 0 overnight. So we've kind of extrapolated that to the 4-month mark. And so the question is, do we protect 30% of our population with 90% or whatever plus efficacy, or do we protect double that population, 60%, 70% at 80% plus efficacy? And that is what we're trying to contend with. And so the rationale for this is essentially trying to protect as many Canadians as we possibly can in the situation that we are with low vaccine stock and everything else that's going on. I think that in general with vaccines, typically longer intervals tend to have better efficacy. We've actually seen now with AstraZeneca that 12 weeks does better than 4 weeks, which is originally what they were studying, right? So I think, we are course correcting. So those who are very severely immunocompromised, so like transplant patients, those with specific cancers, they are getting their second dose in time, but for everyone else, we've taken that stance. Regarding mixing and matching, I think that we don't have as much data right now, but we are actually in discussions to see what happens when we have a delay of stock? So again, Moderna has been delayed for us, right? And so what happens when people are due for their second dose and we don't have ample stock? And can we actually, if the platforms are the same, so Moderna and Pfizer, is there a possibility that we could interchange them?
Mhm.
And then our second situation is with AstraZeneca, because now that it's paused and under 55, what do we do with those that received the first dose of AstraZeneca? What do they get for their second dose? So we
Right.
are actually in these discussions. We'll have more information coming out soon.
Yeah. Okay, so we don't have a ton of time left. So this one will have to be briefer than I would like it to be. But Liz, why don't you go first with this one? What issue do you wish was getting more attention right now?
There's so many. It's hard to pick.
I know.
So I already talked a little bit about long COVID. So I'm going to pick a different one. And I think we are forgetting, like we mentioned earlier, that this is a global pandemic. And we really are seeing there's not an equitable distribution of vaccinations across the world. And for the pandemic to really end and for us to stop getting variants that maybe will have more severe effects, we really need to focus on getting as many vaccines as possible across the world.
Right.
So I really hope that people will start to realize that we can't just think about it on a country perspective, because viruses don't care about borders. We really have to focus on making sure that other countries can also get access to vaccinations, because that's truly the only way we'll get out of the pandemic.
Thank you for saying that. Thank you. I truly appreciate, as a Canadian, I truly appreciate you saying that.
Sabina, what do you think? What issue do you wish was getting more attention?
So I'm a first generation Canadian and I'm South Asian. For me, when we talk about vaccine rollout, the inequity has been stark. And 80% of our COVID cases here in Ontario are in racialized communities, those who are working in essential roles with no workers' protections, no paid sick leave, and now have no access to vaccines either. They're so disproportionately impacted by COVID, and it almost feels like because they're Black and brown, their lives don't matter. And anytime I have airtime to speak about it, I speak about the structural racism in healthcare that exists, because until we don't talk about it, we cannot acknowledge it and address it.
This has been weighing heavily on my mind, especially this week in the United States. We've had another big week in news about the issue of police violence directed at Black and brown people. And Dear Pandemic is also trying to figure out how to use the platform that we have to address these issues of structural racism. So thank you for bringing that up. Well, that is all we have time for today. We do get a ton of questions. I finally read the entire question box late last night. So I'm up to date. Again, I read all the questions that we get in our question box. And even though we don't answer them all, we do use them to figure out what we're going to post on for the next week. So we really appreciate and value the time you take to submit them. If you have a question, you can put it in our question box. It's on our website at dearpandemic.org. And another thank you to Bridges for the Deaf and Hard of Hearing for providing the closed captioning and ASL interpretation so that we can get this message out to another vulnerable group of people who need some equality in language. And if you are using those services, please let us know in the comments. So thanks for joining us. I will be back next week at the same time, 9:30 a.m. Central Time. And again, I forgot to look who I'm going to be joined by, so I have no idea. It'll be a big surprise. So until then, as we say at Dear Pandemic, stay safe and stay sane.
Bye,
Bye
everybody.
everyone.